Thank you, Dr. Davis. It's really an honor and a pleasure to be here, and thank you for the opportunity to talk to you today about, an area that what's one of the great things of these courses. It's pain points, right? We talk a lot about pain points. Where do we struggle? Where do we have success? And when we start seeing variability, it's because we don't have evidence necessarily to drive what's the best or correct decision, but what works well in our hands. So this is a topic that has always been frustrating to me. I have shied away from it many times. When I see it on my template list for the day, I have consternation and angst and not wanting to necessarily go into the room and navigate the complexities of this topic. So what I'm going to intend to focus on is not so much about the why or the how, but what are mechanisms we can use to repair these, and particularly as endoscopic surgeons, a technique that maybe you're familiar with, but if you're not, hopefully this brings an option to you in your armamentarium. So with that, we're going to talk a little bit about the nuts and bolts and mechanics of septal perforation repair, and particularly an endoscopic technique that was more recently described. A few notes about septal perforation. It's overall uncommon, but these are certainly things that we see as otolaryngologists. Our patients are certainly referred to us for evaluation of these. And they can occur for a variety of reasons, with trauma certainly being the most common overall. It is important to consider that if they do not have a trauma history, to ask yourself questions of what may be other diagnostic considerations or pathophysiology that's driving this process. And really I start thinking in my mind about autoimmune, infectious, as well as neoplastic. So some important things that we all think about in our day-to-day, and why it matters to us and why it matters more importantly to our patient, is really the symptoms that it causes. And most patients they fear the nasal deformity. Fortunately, that's the rarest to occur, but these symptoms can really be disruptive to their quality of life. And I think most commonly it's the dryness, irritation, and crusting that is of greatest angst and frequency to patients. Whistling, as well as some of these other symptoms, certainly do occur. So when you're screening these patients, outside of in your mind trying to understand why this even occurred for your patient, some of these symptoms are what often patients will report to us. Now, perforations can come in a variety of sizes and locations, and really I'm going to hone in and focus on the most common ones we see, which is the anterior, inferior, 1 to 3 centimeter perforation. I'm not necessarily focusing on the large subtotal perforation. So we're going to nest our decision making and thought process today in this, which is probably the most common one that we see. And I'm not focusing on those that have had drop of the nose and vasculitis conditions or other reasons. So it tends to be more of the germane and common that we see in our practices. A brief just touch point on conservative therapies that we're all familiar with, whether it's emollients, whether it's moisturizers. And these can be helpful for the dryness and irritation, some of the crusting, but often leave patients wanting for more. There are other options that are non-surgical that are available. It was surprising to me that there is a website, septalbuttons.com, but it does exist. It's actually a very robust website, so it tells me there must be quite a bit of sales that navigate and traverse this web page in terms of its search engine and its optimization, but it exists and people do consider these. Honestly, for me, I have found that they're often more frustrating than successful or beneficial. I've had a few patients that prefer them, but I don't find that this is something that is very common or frequent in my practice. So I'm often scratching my head, what do I do with these patients when I'm seeing this problem? How do I think about it? And again, really not so much in the I'm fearing something more sinister or worrisome from an infectious autoimmune or a neoplastic, but really in the functional day-to-day of how patients navigate these bothersome and disruptive symptoms. There are a variety of techniques that have been published, that have been described, and I bet if this was a facial plastics course, we would be thinking about it probably in a different lens than necessarily how I'm going to present it today from an endoscopic perspective or a rhinologist perspective. So there are a variety of options and methods that have been described, and you can certainly come across these. There's many videos on this as well, too, in your searches that you'll come across to people, and there's certain techniques that they've identified and developed for this type of intervention. But this next topic, or this next technique, really changed my practice. And so this was described by Dr. Harvey. 2019 is when this paper was published. And this really, two things happened with this. One is I now felt more equipped to navigate this in a reliable method in my hands. But two, it demystified some of the complexities of the problem and made me feel actually encouraged that there was something I could offer patients with reasonable predictability of success, no guarantees, but reasonable predictability that otherwise felt reachable. However, it took me a while to really break down the mechanics and the steps of this, and it was certainly a learning process and is a learning process. And that's really what I want to focus on today, is to show you step by step how this can be done, how you already possess the skills in the background to do this, and just a little bit of a leap can get you here to do this if you're not already doing this. And it's really framed around this concept that we can use the anterior ethmoidal artery distribution as a perfusion point or a pedicled insertion into this flap that we can reposition to cover the anterior septal perforation. So in this schematic or cartoon that's in the publication that I mentioned, it's just showing a representation of the anterior ethmoidal artery and its tributaries down into the nasal septum. What is highlighted in yellow is the tissue that we're going to use as our donor. And then the area that's in the green to gray color is actually a wedge of tissue that you're going to remove, which that to me was kind of that leap that I had to take, that trust I had to take that, oh my gosh, I'm removing more from the septum. Am I going to make this perforation significantly larger either during the surgery itself or in aftercare and recovery, and have a surprise that I've just actually made the situation worse? But in reality, it's just a wedge like we often use in facial plastics for mobilization of tissue. And you can move this tissue in a very reproducible and productive way to cover this anterior septal perforation. And so that's what I want to spend the rest of our time, is just talking through and walking through the methods that are used to do this. On the bottom here of this slide is a link to Dr. Harvey's video, and if you're more interested in learning about this, he has a really nice video that's narrated and walks you through the steps. There are others that have YouTube videos as well up too, and so again, if you haven't seen this before and you want to come back or refresh your memory to it, this is a great place to start, as well as the journal articles that support this approach and technique. So this is where it begins. So I've already made the assumption we have a septal perforation. We've already done our diagnostic endoscopy. We're in the operating room for a septal perforation repair. And I want to walk through some of the salient steps that we're going to use. Then we'll put it all together in a video and try to tie it up and understand kind of like how this can be helpful as a tool in our toolbox. So it first begins with identification of the anterior septal perforation. Again, we're selecting that these are smaller anterior septal perforations in that 1 to 3 centimeter category. They tend to be circular to ovoid in shape. And the first thing we want to do is we really want to identify the edges. And what happens with the septal perforations once they're matured is those mucoperichondrial flaps or mucosal edges are going to come over and attach in a scarring fashion. And so what that is essentially created is a fistula inside of our septum of the nose. We need to separate that is the first step of this. Now you can use different techniques. Here I'm showing a pinpoint monopolar cautery at around a setting of 15 to make that incision. You could use an endoscopic tympanoplasty or beaver blade. You could use a 15 blade. You could use a straight beaver blade. Whatever your preferred method is fine. The key is you need to separate these two. That's your first step, is to really try to identify and mature the separation between these connection points of the septal perforation. So this is a 0-degree endoscope looking from right cross-court to left using the pinpoint monopolar cautery to make that initial incision. Then using an additional instrument, in this case I'm just showing a caudal elevator to further develop the separation of those edges. The area that you're going to struggle with the most is anteriorly. Posteriorly on the posterior septal perforation edge, it's direct line of sight. It's very easy to manage that, as well as inferiorly and even superiorly. It's that anterior one that feels like you're working back that feels the most frustrating. For me, the ball tip probe's been helpful to help mature and develop that. Angled scopes can be helpful to do that as well too. But no matter what, it's always going to feel more difficult in that specific area than it does everywhere else around this perforation edge. Now this intellectually was the hardest for me to understand. I've always struggled with flaps and how things move, and all the plastic surgeons, thank you for what you do, because that is super hard for me to understand and apply. And this was that similar concepts were just in the nose of making incisions to then rotate tissue to cover a different area. So this first incision is a vertically based incision on the nasal septum, about 0.5 centimeter to 1 centimeter posterior to the leading edge of the middle turbinate. Now I just said a lot there. find the middle turbinate, come back a centimeter, you're gonna make a vertical incision. The uncomfortable part may be how high you have to go. Now, you don't want to go so high as naturally to be in the cribriform or the olfactory cleft, but you do need to be higher in that space, probably about a centimeter to a centimeter and a half below that is where I would start, and extend that incision inferiorly down towards the nasal floor. Again, you can use sharp, you can use heat to make this incision. Here I'm showing with pinpoint monopolar cautery, but you could also use, again, a tympanoplasty blade or an endoscopic beaver blade. And as you come down onto the nasal floor, you're going to extend that on the nasal floor into the inferior meatus. This implies that you've looked into the inferior meatus, you've identified where Hasner's valve is, and you're making sure you incorporate it in your flap design. And really what we're trying to do is in this overlay on that same endoscopic video, adding some of the cartoon figure to it, is that you'll see in the blue line, that's our incision. The AE8 and its tributaries are marked in between that, and we're going to come next to the yellow incision. So we're essentially going to make two incisions on the septum that preserves that pedicle but also allows rotation. And to get that rotation, what we see here in purple is the area of tissue that we need to excise to allow landing of the donor flap.
I was going to email you. I'm like, dude, we should.
Here's making the anterior incision. Now, what I'm not showing well here on the main picture, but in the insert I'm trying to show, is the key is there's a separation between that blue line and a separation between the yellow line, which are your two incisions. The reason for that is your perfusion point for this flap. Everywhere else is going to be incised, and the rest of the dimensions of this flap, that's going to be your pedicle. So that's the part that I have found that my first few times doing this, that I felt I either narrowed it or I compromised it or I didn't have the right geometry to it. The cartoon looks almost as if they're parallel. In reality, the blue incision is vertical and the yellow incision is more of a 45-degree angle. But making sure that that yellow incision doesn't come posterior to intersect with your initial vertical incision. So there's a separation, and if, again, looking at that insert, that's the perfusion point. That's the pedicle that's going to supply the flap. This is removal of the wedge of tissue that's going to allow this flap to rotate and land into the position that we want to cover over the perforation itself. This is familiar to us, and we practiced this in the lab yesterday from the lens of a nasoseptal flap. So this will feel very familiar. It feels in many ways like a septoplasty or a nasoseptal flap. Whatever instrument you prefer to choose, suction freer works really great for this. Caudal can be helpful for the more difficult attachment points. Another area that has been a struggle for me is oftentimes patients can have a prominent incisive canal that comes up into the bottom floor of the nose, and you may see this when you're doing septoplasties, and it can have this little like cone that comes down into the nasal floor. And I've had times where I've elevated this out and had created a small tear in that area. And the tear is right in that area where I ultimately want to land for the septal perforation repair. So it's definitely a step if you find that your patient-specific anatomy is such that there is this recess towards the incisive canal. Take your time, go slowly, use instruments like ball tip probes. If you do need to separate it, consider sharp dissection once you have it mostly mobilized out of the canal itself. Once you have that elevated, the flap is now ready to be inset and lay over the septal perforation. Depending on whether you're a right-hand or left-hand dominant surgeon, you may raise this flap on the left, you may raise it on the right. Other factors such as persistent septal deviation or spur could also influence that as well too. So I'm showing this all from the side of a left side of the patient and just starting to now redrape the flap or reposition the flap to cover the septal perforation. The flap is actually quite long, and when you watch some of the videos that are published online, and in my video you'll see this as well, you can bring the flap all the way out the nasal vestibule. It's quite long and wide flap, and that's the power of this flap, is that its surface area is very generous. So for these even up to 3 centimeter perforation sizes, it can be quite successful and feel confident that you're getting a repair. This is now viewed from the opposite side, so I'm viewing from right to looking to left, and this is showing, I just highlighted in this white circle, the complete coverage of the septal perforation in this area. So flap mobilized on left and then placed over the perforation. In this case, I have shown that you can use implants concurrently with the flap. In the paper that I cited at the beginning, it was a collagen matrix. There are other extracellular matrix grafts that you can use. pig submucosal or pig intestinal submucosa is a graft that's used or approved for laryngoplasty, tympanoplasty, and septal perforation repair. And there's manufacturers that make that product. So in this case, that's actually what is going in here. And so this is a multi-layered reconstruction in this specific example. And then once you have this inset and the septum is you have your multi-layer repair in position, is then doing some sort of stenting. Early on, I tried the Doyle splint method and found that it was a little bulkier than maybe what I needed, and it was getting occluded, and patients were feeling frustrated. And I should have just went with the guidance of the paper, which is using a silastic stent or silastic sheet, similar to what we heard about earlier for the middle meatal stenting, and it works really well. It's less obstructive. I think it's easier for patients to manage and maintain, and then secure it in place with whatever suture material that you like for this type of repair. So let's, in terms of suturing the flap itself to the anterior landing spot. So you mobilized your flap, it's now coming out to the anterior nasal cavity, much like if you're closing a hemitransfixion incision, whatever your preferred suture method is in that area. For me, it's a 4-0 plain gut on a Keith needle. It works really well in my hands to close that type of flat position in that area. Others will use curved needles or different type of sutures or PDS sutures in that area, whatever you prefer. I like the plain gut suture, not fast, but plain gut in that area works, I think, really well. So let's try to put it all together and just see how this looks like when we stream it together as an entire procedure. So here's our perforation. This here in a moment is just kind of removing some crusting, better approximating it, trying to understand what's underneath. Is there cartilage? Is there not? Is it just soft tissue? And as you saw here, this one's not very large. It's about 1 centimeter by 1.5 centimeters. This is division of the flaps, as I mentioned earlier. This is the pain point, is that anterior one, using whatever tool you like to further separate it. Identify the cartilage. In this case, this was a traumatic septal perforation from nasal cautery, silver nitrate, repeated silver nitrate cautery. That's that vertical incision, so starting off posterior to the anterior edge of the middle turbinate, coming down the nasal septum. I'm just marking this out. I work in a teaching environment, so it's helpful to kind of have these discussions and really try to formulate our plan together. And so this is the reason why I'm marking it here with the suction, or I'm sorry, the pinpoint monopolar cautery, and then actually incising it with the tympanoplasty blade. So this is the 7600 tympanoplasty blade. I like this because I found that for skull-based reconstruction, sometimes with the cautery, the flap tends to shrink a little bit more from some of the thermal effects, so I preferred sharp dissection. We saw this before, just kind of, again, a better approximating and appreciating the relationships of this anterior incision, and then the removal of the wedge of tissue along where the flap is going to now rotate from floor up over the septal perforation here, using a shaver to do that. Again, just really emphasizing the offsetting of the incisions to make sure that you have a pedicle to perfuse blood supply to it. And then now it's the fun part of the easy part. It's just mobilizing the flap. And again, this feels like septoplasty or nasal septal flap. You can see how it comes along the nasal floor. It comes all the way out the nose. It's really long. And then just rotating the flap over to cover it. Your septal perforation, this is just suturing it. Again, 4-0 plain gut suture, confirming that it's complete coverage and in good position, and then insetting the graft material on right side. So this graft material is on the right side of the patient, and the flap is, in this case, was done on the left. And then suturing the stent together and confirming good position. So taking time at the end to just really confirm that you got proper position. One pause on the placing of the silastic is I definitely have had times where putting the silastic in and I've moved my dang graft. So take a moment, just really make sure you've got good, you're holding on to the silastic stent. Even though your flap is sutured, that you're really recognizing that you have a multi-layered repair, trying to get it to sit in the area that you want, and then putting the silastic splints on both sides, and then putting whatever suture you want through, just like you would for Doyle splints, is really the key. Now, what you may notice here too is that the stent is coming up and out laterally on the lateral nasal wall. That is out of intention on the left side, as if you recall, that flap comes down onto the nasal floor, and so all that is exposed bone now from the nasal floor all the way up onto the septum. So this intends to cover that area and really promote remucosalization in all those areas. Aftercare for these is similar to, a septoplasty. For me, saltwater mist or irrigations is really helpful. I leave the stent in place for 3 weeks before I have them come back. At 3 weeks, I'll remove the stents and then perform an endoscopy and debridement as needed, confirm how the perforation repair looks and how it's healing at that time. If you had concerns for delayed wound healing, immune suppression, or any other factor, you certainly could leave these in longer. I would have a low threshold to do that if you had any concerns. But I think 3 weeks is a fair amount of time to leave the splint in place. And again, the doyles, I think, are probably a little bit crusting and obstructing, where this, I think, works a little bit better. So I think septal perforation repair, it's hard. I know for me it's been anxiety-provoking, and I've felt really unsure of how I could best help patients, and admittedly in the past really sent patients primarily to plastics for this consideration and repair. This feels, I think, a little daunting, at least it did to me, but it is, the skill set is there, and it's just taking that leap that you can do this, you have the ability to do it. It can be demystified. Hopefully this gives some demystification to that process, but there are a variety of techniques that you could consider beyond this. The size and location, I do think, is important to consider. There is a follow-up paper that looked at larger perforation size with additional graft materials, or even bilateral nasal septal flaps or AEA flaps. Have not done that yet myself, but it seems like there is some experience with that amongst others. So I think this represents a unique option for us as endoscopic surgeons, and hopefully this has been helpful for you to consider this challenging and complex topic. So thank you again to Greg, and thank you all for your attention.
That's a nice shot. Thanks, Dr. Humphreys. Appreciate it. If we could have the next